because we've already been over it when we went over the T-spine, so it sounds pretty familiar. Okay, so bony thorax. You need to know it's composed of three things. Number one is the sternum. 2, 12 pairs of ribs. And 3, 12 thoracic vertebrae. Okay, the sternum. What's the layman's term for the sternum? I didn't put it down there. What do we call the sternum? Breastbone? Okay, so the layman's term for the sternum is the breastbone. Okay, it consists of 3 parts. I'm going to go from superior to inferior. So starting superiorly, it's the manubrium. We'll talk about it just a little bit. The second part coming down is the body. There's 2 other names for the body, also known as the corpus or gladiolus. And the last part, the most inferior part of the sternum, is the xiphoid process or xiphoid tip, or ensiform process as well. Okay, so starting with the manubrium, I'm going to go superiorly again. On the very superior aspect of the manubrium is something called the manubrial notch. Other names for the manubrial notch is the sternal or jugular notch. So they consider it a depression. It can be palpated. You guys remember what level it sits at? That was a long time ago, wasn't it? T2, T3, close. T2, T3 is the level it sits at. Okay, next thing are something called the clavicular notches. These are also superiorly and laterally located. They articulate with the sternal extremity of the clavicle. Sternal extremity of the clavicle. That articulation is known as the sternoclavicular joint. And then they just called, and there's a cartilage attached to it. But then along the sides of the manubrium, and actually all the way down the manubrium, are what they call shallow depressions. Those are for articulation with the cartilage of the rib. Call it costal cartilage. Costal means what? Rib. Okay. Costal cartilage. Those joints are called the sternocostal joints. Sternocostal joints. Okay, these shallow depressions articulate directly with the cartilage of ribs 1 through 7. This thing's not right, but my skeleton's right. But anyway, so 1 through 7, they articulate directly with the sternum. Okay, and I'll go over the other deal coming up. Okay, all right, moving down, bless you. Talk about the body of the sternum. is the longest segment. And the point where the body meets the manubrium, we call it the sternal angle. Okay, if you remember, you can also palpate the sternal angle. Do you remember its location? T4? T4, T5. The sternal angle is about T4, T5. All right, the most distal portion of the sternum is the xiphoid process, or xiphoid tip, or ensiform process. Do you remember what the level of that is? T10. All right, T10. So it's located at about T10. Any questions about the sternum? Pretty easy bone. For once, huh? Not much to it. Okay, ribs. We're going to talk about ribs, and we already said costo means ribs. Okay, so there's 12 pairs of ribs. They're numbered for the thoracic vertebrae they attach to. Okay, at the anterior aspect of every rib, even though it doesn't, this one doesn't have it on 11 and 12. There's a piece of cartilage. So every rib at the anterior aspect of it has a piece of cartilage on it. And over here, that's known as the costal cartilage. Where that cartilage attaches to the anterior aspect, it's called a costochondral joint. Chondro means cartilage. So they're talking about this right here, costochondral joint. Okay, like I said before, the costocartilage of 1 through 7, ribs 1 through 7, they attach directly to the sternum. Costocartilage of 8 through 10 attached to the costocartilage of 7. So they just kind of come up here and join 7 here. And the last two costocartilage, they just float. They don't attach to anything directly.
So the false ones are 8 to 12?
Correct.
But the 8 to 10
are floating. Okay. All right, so the true, what they call true ribs are 1 through 7. Because they attach directly to the sternum. They call them true ribs. Okay. False ribs are 8 through 12 because they don't attach directly to the sternum. Okay, 11 and 12, they call them floating ribs because they don't attach to anything anteriorly. So they call them floating ribs. The spaces between the ribs, we just call those the intercostal spaces. ribs. So starting with the first rib, it is the shortest rib. And it's the widest. So rib number 1 is the shortest and the widest. You can kind of see it up here. Then they gradually get wider until rib 7. And then they start to decrease in size from there, like 8, 9, 10, 11, 12.
So number 1 is the widest, but it increases
In size.
Oh, in size.
I should say length, huh? Okay, got it. So they increase in length, not exactly width, in length.
With anatomically like this.
Correct.
Okay.
Okay, parts of the rib. So I'm going to start at what they call the vertebral end, which is the posterior aspect. So the vertebral end of the rib is known as the posterior aspect. These are all familiar to you guys. The first part is the head of the rib. So it's this part right here. What does the head of the rib articulate with? The vertebral what? Body.
Oh.
I know you got other stuff on your brain. Okay, the head of the rib articulates with the vertebral body to form the costovertebral joint. Remember that? Okay. So then the next part of the rib, just coming around anteriorly, is called the neck of the rib. It's just the narrowed portion, the neck. Then we have a tubercle, a little bump, the tubercle of the rib. Tubercle of the rib articulates with what? Good, the transverse process. To form what? Good. Forms the costotransverse articulation or joint. Do you remember which ribs have them and which don't?
1 to 7.
Good. 1 to 10. 1 to 10 have them, and 11 and 12 don't have them. Okay, then we're going to talk about the body of the rib. Okay, there's a portion that curves anteriorly. They call it the axillary border, or the angle of the rib. So that's this portion right here of your ribs. So once that gets to that point, they start to point inferiorly. Once they get to the angle or axillary border, they start to go inferiorly, go downward.
You say it's called the axillary border or what?
Angle of the rib. Okay. All right, costal groove. On the inner surface of the rib, there's a little groove that goes around it. It's not really evident on the ones that I gave you, but anyway. So this, on the internal border, I really can't see it, but anyway, there is a little groove, and that's vessels and nerves just go along that little costal groove. Okay, last part is the sternal end. That is the most anterior portion, and that's where the cartilage attaches. The only type of articulation that you need to know for this test is the sternoclavicular joint. The other ones don't, we already did them, don't worry about them. So the sternoclavicular articulation, also make a note, it's on a lot of registry stuff. The SC joints are the only bony articulation between the upper limb and the trunk of the body. I think I've talked about this before.
We did.
It is the only bony articulation between the trunk and the upper limb. It is a synovial gliding type. So that would mean it's what? It's synovial gliding. So it would be a diarthrodal type. Synovial gliding is a diarthrodal. Okay, names of the joints. I'm going to go over the names of the joints, and I'm going to start posteriorly and work my way anteriorly. We just went over it, but let's do it again. So starting posteriorly, the first one posteriorly is the costovertebral. Coming around, the next one is the costotransverse. Coming in the very anterior part is the costochondral. And the last one anteriorly is the sternocostal, but it's just 1 through 7, remember. Sternocostal, it's just numbers 1 through 7. Don't worry about the types of those, just know what they are. All right, there's some terms that have to do with the bony thorax. There's something called a flail chest. Anybody seen that out there? No? Trauma, it would be a trauma thing. That's a condition where the chest wall is caved in from a trauma. There's free-floating structures. It's very serious. Where do you think usually what kind of trauma does that happen?
MBA.
MBA, steering wheel specifically. Specifically a steering wheel hitting someone's chest or them hitting the steering wheel. Okay, the second term is something called pectus excavatum. That's also known as funnel breast or funnel chest. It's also known as bird's nest chest. You've seen it?
Mm-hmm. My friend had it.
Yeah. Snip it. He? Usually it's males. That's funny. Yeah.
It
It's
has a whole face right here. You can press your face in there.
yeah. It's literally there's like a little ligament that attaches from the front, the sternum area, to the posterior aspect of the body. So it's the chest is sunken in, basically. It's kind of bizarre looking. They're born with it. It's congenital. But anyway, that's it. Anybody else seen a pectus excavatum? You have? Yeah.
So it's just like this, just right here, just sinks in.
Yeah.
I think
It's
my
like a
buddy-
little
I think my
hole.
buddy actually has that.
Yeah.
We were thinking for it.
Some people it's really bad, and some it's just like a little. Someone like Masako was saying, it's like someone punched him right in the chest. It's so bizarre looking. Anyway. Okay, the last one that has, and we've had this term before, is called something called a pneumothorax. That can also be very dangerous. What's a pneumothorax?
Air in the
Air in the thoracic cavity.
White slits.
Hmm?
The left slits.
The what?
Isn't it the white slits?
That's atelectasis.
Oh.
Yeah. If it's air, what would it be?
Oh, removal of bronchial markings?
Good. Removal of bronchial markings, or it's a destructive process. So it would be a dark area. And those are also really bad. Remember, we named pneumos as a percentage, like they'll look at it and they'll say that's a 10% pneumo, it's just a little piece. Or 100% is total collapse of the lung. Okay, imaging. Imaging of the sternum and ribs. A couple of things that you need to know. First of all, they recommend 30 inches SID for oblique sternums.
You said 30?
30 inches SID. They might not talk about that much anymore because they're trying to do away with that 30-inch SID. What does 30-inch SID do? We just had that with something. Oh, that's right. What does it do? Magnifies it, okay. It'll magnify it, and sometimes it'll blur things out that you don't want to see because of the magnification. Okay, sternum and trauma, what do you think the most important image would be? Cross-table lateral, that's your answer for anything if they ask you the most important, whatever, and trauma, doesn't matter what you're imaging, it's always the cross-table lateral. Okay, general rules for ribs and sternum first. You should use a low KVP if possible. I know you guys don't set it anymore, but if you hit a sternum and you look at it, it should be a lower KVP. Why do you think?
You don't want to penetrate too much.
Good. You don't want to over penetrate. They're very thin bones. The sternum and the ribs, they're very thin. You don't want to over penetrate. Good. Recommendation is 60 to 70 KVP. Okay, for both of them, ribs and sternum, do them upright if you can. It's easier on the patient.
You said 60 to 70 kVp?
Yes. People that have rib and sternum injuries don't want to lay down. All right. Anterior rib injuries, if it's occurring in the anterior aspect. If possible, do them PA. Why?
Reduce the sensibility.
Good. Puts the anterior ribs closer to the image receptor. That's what you want to see. Puts them closer. So it's the opposite for posterior rib injuries.
You said
If it's anterior rib injury, do them PA, because it puts the anterior ribs closer to the IR. Opposite for posterior injury. If you're posteriorly injured rib, you want to do them AP for the same reason. Puts the posterior ribs closer to the image receptor. Okay, oblique ribs. Oblique ribs demonstrates the axillary border or angle of the rib. So let's just say I did an RPO. Which ribs do you think are going to be elongated? Good. The right side. Okay, so picture your ribs like this. So if you go RPO, the right ribs are elongated. The left ribs are foreshortened. Okay, so an RPO demonstrates the right ribs elongated. LPO demonstrates the left ribs elongated. What do you think it is with AOs? It's the exact opposite. Okay. So if LAO, it demonstrates the right ribs elongated. You thought you were over it with the spine stuff. RAO would demonstrate, I have to do it. The right ribs elongated. I have to do it just, if you guys, I have to do it myself to figure it out. Okay, so it's the affected side down if you're AO, if you want to put it that way.
You said RAO demonstrates the right ribs elongated?
Correct. RAO demonstrates the right ribs. It's the affected side down.
And LAO.
You told us LAO was the right side.
Did I say LAO right ribs? Okay, take that off. LAO left ribs. Okay, so if you're AO, it's the affected side down that's elongated.
So then it's the same as.
You confused me. I'm confused. You said the same thing for RPO.
No, it's the affected side. Wait a minute.
Okay, so LPO, RPO is the side that's against the IR, right?
Hang on, I gotta think. My thinking cap isn't on this morning.
You should use the skeleton.
Like this, okay. Alright, so if I'm RPO, it's the affected side. POs, it's the affected side down,
For A.
and AOs, it's affected side up. Did I say it exactly opposite? Sorry. Good idea, Drew.
So affect the side down and AO is affect the side up?
Correct. All right, everybody got that right? Sorry.
So then
Confused.
LAO.
LAO shows the right.
The right ribs. LAO, it's the right ribs elongated. RAO, it's the left ribs elongated. AO, affected side up. PO, affected side down. Okay, last two things. We usually do ribs in sections, upper ribs and lower ribs, just because of our technique. Upper ribs, you take in a deep inspiration and then expose. Why do you think that is? Good. Because when you take in a deep breath, the diaphragm moves down. Okay, so you want it to move out of the way of the upper ribs.
Deep exploration.
Deep inspiration. Don't tell me I said expiration. So upper ribs, deep inspiration to move the diaphragm down. Lower ribs, expiration to allow the diaphragm to move up. So you see more lower. All right, that's it. So let's get started with lab. Let's do maybe 10 minutes and you'll be done with lab in a half hour. Okay, that way you have time to study.
Someone make my notes up at this point. So I just want to send it comprehend.
Hopefully I said everything.
No, yeah, I got what you were saying.